Good morning, everyone, and thank you so much for participating in today's presentation. Unfortunately, we can't see your faces, so if you're falling asleep, I'm sorry, I won't be able to tell. This won't move. There we go. So first of all, we'd like to acknowledge as we gather here today that we are on Treaty 6 territory and homeland of the Métis. We pay our respects to the First Nations and Métis ancestors of this place and reaffirm our relationship with one another today. So the learning objectives today for our presentation is first to just do a general overview of Sanctum Care Group, our organization, and who we are. Then talk a little bit about the community landscape as it pertains to Sanctum 1.5, which is Canada's first and only HIV and high-risk pre- and postnatal care home. We're going to talk about some of the type of interventions that we provide at Sanctum 1.5, as well as some of the outcomes that we've seen in working with this population. And then we'll also give you an overview of PORT, our prenatal outreach and resource team, which is our newest initiative that launched in November of 2021. So just a couple months under our belt with that program. So Sanctum Care Group is a group of interagency professionals who work directly with populations affected by HIV, addiction, mental health, homelessness, and poverty. In 2013, we formed the non-for-profit Sanctum Care Group with the intent of opening up Sanctum, our HIV hospice and transitional care home. Sanctum is managed by our volunteer board of directors. So Dr. Maurice Markington is the co-founder of Sanctum Care Group, also a physician at Westside Community Clinic and an addiction specialist. Jean Morrison, the CEO of St. Paul Hospital. Dr. Peter Butt, an addiction specialist. Dr. Jocelyn Martel, she is an obstetrician and gynecologist. Stephanie Kovchuk, who is the CEO of Tourism Saskatoon, Dr. Chris Thompson, who is a plastics surgeon, Gilbert Qstep, who is a well-respected elder in our community, Nilesh Kavia, who is the VP of Affinity Credit Union, and Helen Semagamis, a lawyer here in Saskatoon. So the organization as a whole's goal is to address gaps in the health and social systems that adversely affect the populations that we work with. So in 2013, when we founded the organization, we were seeing a large group of our HIV positive population falling through the cracks of our healthcare system. And for those of you who don't know, Saskatchewan has the highest rates of HIV in North America, equal to that of sub-Saharan Africa. What makes us unique is that the vast majority of transmission in our community happens through injection drug use. And so this population was going into hospital to receive treatment for whatever acute infection had landed them there, usually related to their injection drug use. Typically treatment for those infections, lasted about 6 weeks. But what we were seeing was because this population was living with multiple stigmas, as well as, many factors such as homelessness, poverty, addiction, trauma. They weren't staying in hospital because acute care systems really aren't set up to address those types of issues. And so they would leave hospital against medical advice, go back into the community, and then eventually cycle back into the acute care system to receive treatment again. The problem was that not only were they not receiving treatment for their acute infections, more importantly, they weren't having the social drivers of HIV addressed in an acute care setting. And so that's really where the vision for Sanctum was developed, that we could create an alternative model of care that was really rooted in the needs of this population, that would better support not only treatment of infections, but also create opportunities and supports so that these individuals could manage the symptoms of their disease in the community without relying on the acute care system. And so Sanctum was funded not because there was a particular interest in supporting our HIV positive population, but rather through a cost benefit analysis, we were able to say to our government, look, if you fund this model, not only will we improve the health and social outcomes of this population, but we will reduce acute care visits, we will reduce admission into hospital, and we will reduce length of stay in hospital. And so based on our proven outcomes, so we've been operating now since November of 2015, we exceeded all of the expectations and outcomes that we had predicted that we would meet through this model of care. And as such, have continued to receive funding to expand our programming to continue to support individuals who are marginalized in our community. So most of our programs, or I should say all of our programs, are funded jointly by the Ministry of Health and the Ministry of Social Services. And that is really, it is a bit unique in terms of how we're funded, and that's because our model is very integrated. So we're improving not just the health outcomes of individuals that we work with, but also the social outcomes. And so that's why we are funded jointly by both the Ministry of Health and Social Services. So the programs that we currently run, I just talked about Sanctum, which is our HIV hospice and transitional care home. So we take individuals who are HIV positive directly from hospital once they are subacute and provide wraparound integrated support and care to them in our home-like environment. We also provide palliative care. So we palliate individuals who have a palliative diagnosis who are also HIV positive, and allow them to die with dignity within the walls of Sanctum. We also operate HEART. HEART was really established, it was established in 2017, and that was after our first year of kind of fully operating Sanctum. A lot of the individuals who were coming into Sanctum really didn't want to leave, and because we have only 10 beds, we also had extensive wait lists of individuals who really wanted to come into our program. So that's when we decided to launch HEART, which is kind of like Sanctum, but on an outpatient basis. So still providing that interdisciplinary approach to care, but able to support clients in hospital, and then transition them from hospital into community while addressing all of the psychosocial issues that present with those clients. And then in 2018, we opened up Sanctum 1.5, which is Canada's first HIV and high-risk prenatal care home. I'm going to go into some more detail about that program, and then obviously most recently Port, which I'll also go into a little bit more detail further on in the presentation. So our vision is, as an organization, is for a community in which individuals requiring our assistance are able to attain their optimum level of health from their perspective. And the emphasis really is on there. We do not dictate the care that our patients receive. We allow our patients to dictate what they want for support from our agencies, and then we provide that support. Lucky for us, most individuals' goal is to be healthy and happy, and so with that usually comes a very, not only integrated case plan, but one that it brings value both to us as an organization, but to the individual who is seeking out their goals while they're in our program. And we recognize the need to provide care with humility and without prejudice. Our vision is achieved with a philosophy of harm reduction, trauma-informed care, and is demonstrated through Sanctum's core values of compassion, collaboration, and innovation. And now let Kathy go into a little bit of detail about our programs.
Whoa. Awesome, I wasn't supposed to take this slide. That's okay. I'm sure you're sick and tired of hearing her voice anyways. So what do our programs include? So we offer an integrated wraparound and holistic care approach. We address all aspects of the individual, physical, spiritual, emotional, and environmental, recognizing that Western medicine is not really great at focusing on all quadrants of the medicine wheel. That is where we really put our focus on is getting that balance amongst the residents that we work with. We are a multidisciplinary team. We offer medical and social support as part of our staffing model. We integrate a lot of our community agencies, as well as a lot of the staff that are employed by us do have relevant experience in addictions and social work. So we do have addiction support and interventions. We do bring in addiction workers. We will also assist our residents in accessing treatment if that is what they if that is what they're desiring. Working with them to get on an opiate-assisted treatment if that is what they are. If that is what their goal is. Social work, we actually do have social workers in our program. Social workers are integral to the residents that we work with. They are the ones that get the ball rolling the minute our clients come in, our residents come in. They begin immediately working on addressing all of those gaps in that individual's portfolio, be it housing, finances, etc. We do have a peer support program. Peer support program consists of residents that have gone through the program at Sanctum itself. They work for us 2 days a week, 3-hour sessions. And what they do is they meet with the residents at Sanctum, and through their own volition and their own planning, they address and discuss topics that are chosen by themselves and the group of residents. They have, we do not intervene with their programming. We don't even really eavesdrop on it. That is their time. They do an amazing job. Our volunteers are so proud to come back and work with the organization that and I'll quote one of our current peers, the organization that saved my life. It is truly wonderful to see that. We do have pet therapy as well. Each home is equipped with a dog, a pit bull lab cross at Sanctum, and then an oversized and probably undersized brain of a Newfoundlander here at Sanctum 1.5. He's like a large bear, but certainly is really, really soothing and very welcome amongst all of the residents. And we continue with all of the support as our residents transition into the community, connecting them with all sorts of healthy supports and networks as they are with us, and then as they go forward into the community on their own. So what does our program, what is different, or what does our program include? We put ourselves, our organization, on 2 very strong pillars. The first pillar is harm reduction. Harm reduction is what informs the care approach that we have at Sanctum. Harm reduction meets the individual where they are at. It does not imply any judgment. We do not judge our residents for where they are at in their journey. We are non-stigmatizing to them. We will work with them unconditionally, no matter what where they are in their journey. If they are using substances, if they are under the influence of substances, we do not remove our residents from our program for those reasons. What we do is we provide information to them. We teach them how to engage in substance use, but do it safely if that is where they are wanting to continue in their life. We do not say to them, you know, you're using substances, it's not really good for you. We need you to stop. We need you to go into treatment. No human being is going to do what they are told, and our residents are no exception. So what we do is we meet them where they're at. What are your goals? How do you want this to play out for you? What information do you need? What are your practices? What are your current practices, especially around injection injection use? Are you accessing clean needles? Do you know where to find clean needles? How are you using? Are you using with are you using alone, which is really a very dangerous practice, because that is where we find a lot of our overdoses. We do work with our residents. We teach them naloxone, how to use naloxone. They leave all of our residents leave our programs with naloxone kits, knowing how to use them. What we do is we provide a path for recovery if that is what they are wanting. They and they alone will determine when they are ready and how this is going to play out. Trauma-informed care is the second and equally important pillar to our program. Trauma-informed care recognizes the deleterious impacts of physical and psychological trauma on an individual. Most of the individuals that we work with have come from a very diverse trauma background and very, very robust trauma background. Many of the individuals that we work with have had trauma incurred from a very young age, infancy onwards. We do know from research that trauma that has been incurred through childhood is likely the most refractory to working through as an adult. Adverse childhood events, all of those trauma events that happen to a child will, if not treated, will result in an adult who is more prone to be a risk taker in their life, who may end up through lifestyle, through poverty, and also through brain changes that are incurred from ongoing unresolved trauma. They may be the ones that are substance users, are incarcerated. They are the individuals that we work with. We do know that 80% of the population has been affected by trauma in varying degrees. Trauma is responded by on a very individual basis. So two people can go through the identical circumstance and their response may be different, and that is just the individuality of the person. It is their perception of the events and how they process that. We do, based on the fact that trauma is so prevalent in society, we do apply a universal trauma approach to our care. We recognize that trauma brings about behaviors. The behaviors serve a purpose. Oftentimes those behaviors come out when stressful situations occur. It is a human reaction to think, oh, yeah, they don't really like me, they hate me, whatever, they're mad at me because they yelled at me, they called me a name. Trauma and their response has nothing to do with us. It has everything to do with the environment that they are in and the perception of them in that environment, because they are constantly in a fight and flight response in their lives. We do not provide trauma counseling. We provide a safe environment, a trauma-informed environment where all of our individuals that we work with are met with dignity, they are met with respect, they are met with understanding, and that non-judgmental approach is really where it is at. We get to know the stories of these individuals. Knowing the stories allows us then to ask or to understand what has happened to them, instead of taking an often usual approach of what is wrong with that person. There's nothing wrong with them. It is what has happened to them that brings us to where we are today. We're going to move right on to Sanctum 1.5. I believe we have a video, and I'm going to hand this over to Kate because she's technological and I'm not.
Women need a chance. They want to change. They just need people to believe that they are going to change and not judge them based on their bad decisions. When I first tried crack, I was 12 years old. Started shooting up when I was 13, working the streets at the same time. I remember when me and my mom used to work like right across the street from each other, like kitty corner. It was like horrible. Like I woke up one morning and said, oh, I want to be an addict. I want to be strung out on East Hastings Street, you know? My lifestyle led me to that. I didn't plan to be pregnant. I wasn't going to keep her. Just the lifestyle I was living and having a kid and having it taken away. Couldn't go through that again.
The women that we take into our program are women we know will have their children apprehended. Oftentimes, women who are struggling, who are pregnant, don't receive services until after the baby's born. And so that's really counterproductive to keeping moms and babies together. And it's also counterproductive to having healthy pregnancies and health outcomes for both mom and baby.
When I first found out that I was pregnant, I actually was living in the hood. So bad, people didn't even take off their shoes because there were dirty needles, there was cockroaches and mice. My one buddy who was a gang member that I was pregnant, and I told him that I was going to keep my baby, and he looked at me and he said, that is the stupidest thing you could ever do. You'll be sitting in the hospital room holding your baby and they will come and take her right from you. You'll see her for 5 minutes and you'll never see her again. I really felt kind of hopeless, just thinking like there's nothing I can do at this point. When I was asked about the program, Susie had walked in. She pretty much told me there's little chance of you leaving the hospital with your daughter. She's like, I don't know if you're planning to keep her. And I thought, well, if that's an option, then of course I want to be her mom. I want to be there for her. She said, what if I could tell you that you would leave with your daughter from the hospital, but you could come and stay at Sanctum? I thought, yeah, I want to be a part of this.
The strength and the resiliency of the women that we've had the privilege to work with is unprecedented. They want so deeply to be a mother and a good mother. We don't look at them and say, what do you know, what do you don't know? We direct them in a more rounded approach. Some moms may need help mixing formula. Some of them may have never mixed formula before. It's the basics. This is how you wash a baby. This is how you diaper a baby. We show them baby being weighed. We show them that, hey, baby's growing. You're doing such a good job.
If Legacy had got taken away from the hospital, my recovery would not exist right now. I would be numbing the pain of not being with her. Sanctum has helped me realize that I can, and I do deserve to be a mother. When Kathy told me that, it made me cry, because I've never had anybody tell me that before, that I deserve to parent Legacy and that I deserve to be her mother.
For many of them, this is the first time they've been given the opportunity to demonstrate that they can parent. So it's a fresh start for mom, but it's also a fresh start for baby. Not only through the perinatal stage are we increasing health outcomes for baby in terms of having a healthy pregnancy and for mom, but more importantly, that baby is going to bond with its mother. And that attachment is so critical to the development of that baby moving forward.
The need in Saskatoon for an organization like Sanctum 1.5 is enormous. I can't even find the words. I mean, Katelyn has provided a structure and a model that doesn't exist elsewhere, but meets the community right where they need the help. Being able to anticipate and respond to those needs in such an individualized way, and in a community of women that can be very difficult to engage, is a monstrous task, and they've done it beautifully.
When I look at the women that have come into our program and have graduated into the community with their children, I think about how different it would look if we weren't here, and that scares me because those women have demonstrated in a very short period of time that not only are they capable, they are amazing parents and they love their children.
They made it easier for me by just being there for support and emotional support whenever I needed them to talk. They were there, they understood. They didn't judge me. They made me feel accepted and normal, like, you know, like I'm not someone who should be shunned and put in the corner and, like, you know, that I'm a horrible person for what I do. They made me feel like I was human.
Sanctum pretty much like cared about me until I was strong enough to care about myself. And now I have a home. I even have the hopes that I'll get my son back in my life. There's actually potential for things to get better. I owe everything to them.
So when we thought about opening up Sanctum 1.5, what we were seeing in the community was, you know, oftentimes women were pregnant, but lacking a lot of support. So women who were experiencing, you know, issues related to substance misuse, to homelessness, to poverty, to untreated mental illness, sex trade involvement, exposure to violence, these women were struggling in our community with very limited support. The Ministry of Social Services doesn't have a mandate to work with these mothers until the infant is born. And, you know, other than, you know, one program ran through the Saskatchewan Health Authority, there was no designated program for high-risk women in our community. And so what supports were being offered weren't enough, because these women, because of the circumstances that they were coming from, were in a constant state of crisis. And so rather than any prevention planning taking place for mom and baby, it was really just about managing the crisis that was kind of occurring from day to day. And so these women would end up going into hospital, have their children apprehended, causing more trauma to that already very traumatized mother. And then sending mom back to the same environment she came from, with the expectation that she, you know, case plan to have her infant returned, which oftentimes when you're struggling with all of those things, that's a fairly daunting task. The other thing is that those moms weren't having an opportunity to bond with their infants. And we know that that bond is a huge motivator in changing your circumstances. So the system was really, you know, reactive, and there wasn't a lot of preventative services in place. So we thought, what if we could create a space where we could address the basics of life, like housing and nutrition, but also put in other supports to address the psychosocial issues that lead to babies being apprehended at birth. And that's really where Sanctum 1.5 came to be. And so the goals of the home are to prevent vertical transmission of HIV for women who are HIV positive and not engaged in care, and women who are at risk of contracting HIV while pregnant. So for those of you who don't know, if you're HIV positive and on your medications and pregnant, the chances of vertical transmission to the infant are less than 2%. If you're not on your meds, which typically happens if you are living a chaotic lifestyle, the chances of vertical transmission then go up to about 25%. If you are not positive but engaging in behaviors that put you at risk for transmission of HIV while pregnant and you were to contract HIV, the chances of transmission then skyrocket because you're seroconverting the virus while pregnant. So that's why our model is not just for HIV positive women who are not on their meds, it's also for women who are injecting drugs during pregnancy. The other goal is obviously to improve the health and social outcomes for vulnerable women and their children. So, you know, by providing women with some stability during pregnancy, we can increase their engagement with health services, that prenatal care piece, improving their nutrition, even sleep. I mean, we see moms come into our program who sleep for days because they've been wandering the streets homeless, right? So, and then by applying the interventions that we do, we prevent children from entering the foster care system. So again, a very integrated wraparound approach to care that is rooted in harm reduction and trauma-informed care. And obviously, when we say harm reduction at 1.5, it looks a little bit different because we're applying harm reduction within the broader context of child welfare and keeping infants safe. And so women who come into our program, all of the women who come into our program are actively using, and there may be use during pregnancy, but if the goal for that mother is to parent their infant, then we support them in achieving sobriety so that when baby comes, they are able to parent their child. Just, you know, the other kind of factors that led to Sanctum 1.5 was, you know, there had not been any vertical transmission in our community for some time. And then in 2015, we started to see a spike of children being born with HIV. And, you know, in a country with the best health infrastructure in the world, it's, you know, really hard to wrap your head around why we're having babies born with HIV. And that really comes down to the social drivers that lead to women experiencing chaotic pregnancies and the lack of support that exists in our community. At the same time, we were also seeing the rise of crystal meth, resulting in an increase in disconnection to care with this population. So Sanctum 1.5 obviously is a prenatal home for moms living with HIV or who are at high risk of contracting HIV while pregnant. It's also a postnatal home. So when women come into our program, more times than not, they are pregnant. We support them through pregnancy. We then support them through labor and delivery. And then they transition back into our home with our support with their infant, where we continue to support them. All the while dual case planning with the Ministry of Social Services. And typically the stay here is about 3 months. And at the end of that 3 months, we transition women into the community or into other supportive transitional programs that are already in existence to continue that support for mom and baby. So the referral criteria for Sanctum 1.5 essentially is that they're either HIV positive or there is injection drug use and pregnancy. Typically, if you have injection drug use, which is our criteria, then your child is at risk of apprehension. But the moms who come into our program are struggling with a multitude of issues, from substance misuse to their other children being in care to untreated mental health, homelessness, etc. You must be resident of Saskatchewan. And the other piece since opening is, well, our initial goal obviously is to provide that prenatal care and support because of the extensive wait lists that we have, because we only serve, I mean, we have 10 beds, but we serve the entire province. Our wait list is always long. And so out of real necessity to try and support as many women as we could with the prevention of those apprehensions, oftentimes now we are taking moms from hospital after they have delivered the infant and when, you know, there's risk of apprehension there. So again, because of our wait lists, you know, we're shortening the time that we're providing the intervention for these women in order to support as many women as possible. It is not ideal, but it is, you know, an issue that we are faced with. So what we do offer, and maybe Kathy, do you want to cover some of it?
Sure. So at Sanctum 1.5, we do have a program director, registered nurse. That is yours truly. We've partnered with Westside Community Clinic. We work with an amazing nurse practitioner, Della Magnuson, who will round once a week here at Sanctum in person. She's also pretty much at our beck and call if we're needing any sort of assistance with prescriptions, if we have questions about our moms, and sometimes our infants as well. We do work very closely with addiction specialists. Most of them are coming from Westside Community Clinic. They will round as needed, but more often than not, our moms are going to the clinic to meet with these addiction specialists. We have a dedicated, pardon me, psychiatrist that we have integrated into our program for the last year, which has been really, really amazing. This psychiatrist actually makes house calls. And of course, now in the pandemic, she makes phone calls. The women, our moms really, really enjoy her. She is very helpful, and she's really timely for us. She really understands our population and the nuances around substance use, as well as the psychiatric components. So it's been a real value add for us. We have a pediatrician who comes weekly. Sometimes she will come a little bit more often if we have an infant who is in withdrawal, or we are starting morphine or something for Eat, Sleep, Console. She is absolutely phenomenal. A lot of our infants that we work with can be a little bit more complex than than infants who are born to healthy moms who are in a much better socioeconomic position than what our moms are. So we do find that oftentimes we're calling our pediatrician, every other day for concerns. And just like our nurse practitioner, our pediatrician is at our doorstep very, very quickly. So we're really, really fortunate for what we have for supports. So what do? We do, as Katelyn said, we provide a wraparound integrated support and care, partnering with community agencies, and again, looking at that holistic approach, the mental, the physical, the emotional, the spiritual, planning those individual case plans. So important. All of our moms come in, even though they have the same goal. They all come from their own separate journeys. So case plans for resident A will not apply to resident B. We're really, really fortunate that we have that ability to individualize what we do. There are rules at Sanctum 1.5. There are a few standard basic rules which will apply to everybody. But again, just like the individual case planning, we cannot apply rules or suggestions or even some of our practices to all of the moms unilaterally, because they are all very individual. Sometimes our moms will question that and say, why is it like this for me, and why is it not this for the other person? But when you sit down and you explain to them, you're all on your own journey, and at the end of the day, at the end of your 3 months, you all have one goal, and that's to leave with that baby in your arms into the next chapter of your lives. So let's focus and let's work on the individual plans and the approaches that you'll need to get that goal completed. They understand that, and that usually settles the questions quite well. Again, harm reduction, trauma and violence informed approach. As Katelyn said, our moms come from profound trauma, so much interpersonal violence, and oftentimes those adverse childhood events, our moms have not had the role models, and they don't have that touch point of what a healthy parenting or healthy mother-child relationship is, because so many of our moms have come from the foster system. So applying that holistic approach again is really the way to go, and it is the key to the outcomes that we do have. As Katelyn also said, we do not, we have a harm reduction approach, but it is definitely a little bit different than over at Sanctum. We work with each of our moms. We understand that relapse and recovery go hand in hand. We are working with our moms on their individual goals. Family treatment when we can make those arrangements. Treatment specifically just for moms, whatever it is that they are needing. Again, working with mental health and addictions in the community and connecting them to those supports is going to be paramount for the success of our moms. You know,
I just want to add one thing. Admission into 1.5, you don't have to want the parent. We do have moms who come into our program who really just want that safe pregnancy and aren't interested in parenting, and that's okay too. It's not a reason for us to not take an admission. So we work with every mom individually in determining if parenting is what they want, if adoption is what they want, or in cases where we know mom won't be able to parent, we do extensive kin research with the Ministry of Social Services to locate a healthy family that can support that infant once born. And the goal really there is to prevent that interface with the foster care system altogether wherever possible, so that, you know, it just changes the dynamic too. I mean, the moms are then empowered to make the right decision for themselves and for their infant. So I just wanted to make that clear that we don't require, you know, it's not a requirement to want a parent to come into this program.
so what we do weekly talk screens on all of our moms. If we are concerned at all about substance use, we will do a point of care talk screen as well. And then based on the results, we will formulate a plan with mom in response to that. Since the pandemic has started, we've not had the ability to use Larson House for brief and social detox as we did pre-pandemic. So we have began detoxing our moms in their rooms, putting a phrase in place of suspended parenting, where mom who is under the influence does not provide care to that infant until she's in a little bit better place, a little bit more stable after the use. Supervised parenting occurs after that. Supervised parenting gives the opportunity for mom to meet with her supports, to do some case planning. It also gives her that window of opportunity to rid herself of the substances. Once we have a clear talk screen, again, mom is off supervised parenting and on to parenting alone. What we do find when we detox our moms here at Sanctum, we maintain that bond. Even if mom is on suspended parenting, she hears her baby. In supervised parenting, mom is allowed to feed baby, to interact with baby. They're just doing it under supervision of the staff. It is empowering to mom. It is also a really phenomenal driver for change, motivation for change for our moms. We do offer cultural support. Everything from where is mom at? Does she wish to re-engage or reignite her cultural practices? If not, even applying some of the teachings and bringing it into context for our moms, it allows an extra lens for which they can look through when they're honing the skills of their parenting. It helps them understand not only the role of a parent, but where they're coming from as well as individuals. Life and parenting skills, definitely something that is so important. Everything from how to make formula to banking, banking skills, finances, cooking, sometimes even cleaning, but I think we could all use that from time to time. All of the skills that many of us are privileged to grow and develop as we grow up, but by virtue of foster care system, socioeconomic disparity, etc., the skills just have not yet been honed. But honestly, our moms, in spite of the fact that they may not have been taught all of the parenting nuances, they are amazing mothers. They take the ball, they run with it, and they do amazing at their job of mothering. What we don't do at Sanctum 1.5 is we don't shame and blame for moms who are struggling with their substance use, and that often is the anticipated reaction, and that comes from, you know, multiple interactions between society, between health. You name the institution. We are a judgmental society. So when we don't shame and blame, and we actually sit down and acknowledge and plan around substance use, we provide a venue for change, and we provide empowerment for growth and change for these moms. Having your child, holding them closely, is such fuel for change. It is, the unfolding of it is nothing short of magical here, without magic being applied. Like Katelyn said, we do not, we do apply harm reduction in a slightly different lens than over at Sanctum Care Group. We do not allow women to use in the home. We work with them. We do recognize, as I said before, that relapse is part of recovery. Holistic approach. As I said, we do have cultural support, which explores many aspects of our mom. We also partnered, formed a community partnership with Hands at Work. So Hands at Work is a non-for-profit organization. I won't get into the whole details of them, but what the intent of our linking with them is, we link our moms with volunteer families. And mom and baby are linked with several families. What they do is they provide healthy relational community support. Sobriety demands a change in your support system. Many of our moms do not have healthy supports at all. So having a healthy relational support is really, really key in success for our moms in the community. It takes away that loneliness. It allows them interactions with under a healthy relation guise. And as the relationship with our families grow and our moms, it's amazing. Some of our moms have gone on trips, you know, day trips, shopping trips, things like that. So it's been quite neat. Sanctum 1.5 uses Eat, Sleep, Console to manage neonatal abstinence syndrome or withdrawal in infancy. Many of our moms utilize opiates. Eat, Sleep, Console does not just solely speak to opiates. Babies can withdraw from a variety of substances, including a variety of antidepressants, stimulants as well. So traditionally, how they would manage the withdrawal in hospital was the infant was placed in NICU in a very noisy, very stimulating environment, separated from mom. A lengthy and very subjective assessment would take place of that infant. Depending on how that infant was scored, dictated whether or not this infant would require opiate initiation. Opiate initiation in hospital oftentimes was lengthy, and in an environment of stimulation, of noise, bright lights, and not having mom at their beck and call, often led to that that long stay on opiates. It does not conform to current best practice. It doesn't foster the bonding and attachment. And of course, hospital stays are very costly, especially in NICU. So what we have adopted and adapted here is Eat, Sleep, Console. So it's a non-pharmacological approach to managing neonatal abstinence syndrome. It is now considered the best practice, and it is 80% as effective as applying pharmacological agents to managing the neonatal abstinence. We score our babies on 3 parameters: their ability to eat. Are they organized enough to eat? Can they get enough nutrition in? Are they sleeping? How long do they sleep? Can they sleep for at least 1 hour at a time uninterrupted? What is their consolability like? Infants who are going through severe neonatal abstinence oftentimes are not easily consoled. What we do find is if we apply techniques, the biggest and most profound technique is allowing mom to have skin-to-skin contact with her infant. We can place them in a quiet, non-stimulating environment. Mom is taught different methods on how to try to calm and comfort her infant through the withdrawal. And what we have found is that we've had very few morphine starts or opiate starts to manage neonatal abstinence here at Sanctum. When we do, it is guided by a pediatrician. I've kind of went through this already, so I'm not going to belabor the point. The most powerful thing about Eat, Sleep, Console is it promotes that healthy bonding between mom and baby. And when mom and baby are bonded, mom is going to be empowered for her own recovery as well. It is extremely cost effective. And yeah, it's totally revolutionized neonatal abstinence, and actually acute care is now adopting Eat, Sleep, Console in the hospital as well. Again, our holistic approach, we work on life skills, parenting skills, referrals to the community supports. I'm going to pass this over to Katelyn right now because she's going to take you through some of our stats.
Yeah, so just in terms of most common reasons for referrals to Sanctum 1.5 include being HIV positive and not on your ARVs. We have a significant amount of women who are pregnant in our community who are struggling with homelessness, women who have other children in care, a lack of prenatal care, gang involvement, sex trade, and exposure to violence are the most common reasons for referral. And to be clear, it's usually not just one, it is a multitude of these things combined. So just to kind of go over some of the data from our program. So this slide basically looks at addiction support stability on admission into our program. So how stable is the client in terms of their addiction when they come into our program? 66 or 67, I guess, % of our moms have inadequate addiction support stability, and then 31% have partial, and only 2% of the population that comes into our program has stable addiction support stability. So on discharge, you'll see that we also measure this. So we measure both on admission and discharge. On discharge, 56% now have stable support for their addiction. 29% have partial, only 10% were inadequate. And then just a small number there with no use. We also look at the housing status of moms who come into our program. So where are they at when they come into our program? 50% are homeless. 26% have stable housing, and about 22% have partial. So again, a large portion of our population are either homeless or inadequately housed on admission, and then on discharge, 81% of the moms who come into this program transition into stable housing. About 12% had partial, so not stable, but partial housing, and then 8% had inadequate housing when they left our program. We also look at the supports that moms come into our program with. So again, 52% on admission have inadequate support, 40% have partial, and then 6.9% have stable. Then on discharge, we can see that 67% of our moms had stable social support on discharge, 26% had partial, and 6% had inadequate. So since opening, we have served 78 mothers in our program. What I want to draw your attention to on this slide is, first of all, that we've had no babies born to moms in our program with HIV. But more importantly is the placement of the child, which is a big focus for our program. So 80% of the moms who come into our program who are at risk of having their child apprehended at birth leave the program with their child and transition into the community. 15% of our moms placed with family, 2% placed with a private placement. And we've had, of the 78 children that have come into our program, only 2 have gone into the foster care system, and that was after an exhaustive family search for those mothers. So in terms of that outcome, you know, our organization is really proud to say that we have a 98% success rate in preventing children from being apprehended at birth. In addition to that, of the mothers who have graduated from 1.5, an additional 44 children have been returned to their care, resulting in a total number of 120 children either prevented from being apprehended at birth and or returned to their mothers from the foster care system, which is another stat that we're really proud of. You know, obviously, our intervention is for the prevention of that child being apprehended at birth, but the impact is far greater when we look at the amount of children who are now being returned to their mother's care. I just wanted to briefly cover PORT, our newest program, which is our prenatal outreach resource team. So kind of like HEART evolved out of Sanctum, PORT has evolved out of 1.5. Again, Sanctum 1.5 only has 10 beds to service the province and an extensive wait list. We also have alarming rates of children being apprehended at birth in our community. And so PORT is a response to that need and allows us to create a team essentially that does not, like, so within Saskatchewan, there's no team dedicated towards working with pregnant women, which is concerning because there is a small window of time. You have 9 months to provide an intervention, right? So that was really our pitch to the government, is that we need to have dedicated teams working with women who are pregnant and at risk in our community. And so PORT has launched here in Saskatoon. We'll be launching in Prince Albert, and then from there we'll be launching in Regina. The referral criteria is much more inclusive than the referral criteria for 1.5, in that we will take any woman who is pregnant who has any risk for apprehension. So that could be the, involvement with the ministry. It could be mental health and addictions. It could be, STDs or HIV. It could be domestic violence. It could be housing. Really, any reason at all that woman might be at risk of having her child apprehended is reason for PORT involvement. The goals of the program are very similar to 1.5, to mitigate the risks associated with infants being apprehended at birth, to provide access and support for obtaining trauma-informed, culturally safe, stigma-free treatment and care, and to provide access and support through the harm reduction and prevention strategies that can lower health risks for this population. Obviously wanting to increase access to prenatal care. For those of you who don't know, syphilis has reached epidemic levels in our community. We're seeing rates that we've not seen before, you know, and again, related to just a disconnect from the population we serve to the service providers that currently exist. Providing stability to women during that prenatal period, so getting them access to not only optimize their health outcomes, but also those social outcomes. So, you know, direct lines to housing, to addiction support, to trauma counseling, whatever it might be that that individual needs at that time. And also to, much like at 1.5, you know, prior to these services being offered, if a child goes into the foster care system, so first of all, the ministry, because they don't have a mandate to work prenatally, even if they, even if the mom identifies and we know that a mom can't parent, there's no work done in terms of looking for healthy family until the infant's born. So that infant still goes into the foster care system, and then the Ministry of Social Services has about 18 months to provide a permanent plan for that infant. So that infant can linger in foster care for up to 18 months. Our goal is to ensure that if a mom is unable to parent, that we can locate healthy families so that before baby's born, so that when baby is born, that baby goes directly to that family, and it doesn't have to interface with the foster care system that often leads to attachment disorder in this population. So we offer case management. We have direct lines to our physicians at Westside Community Clinic, as well as obstetricians on MAT services. So oftentimes, especially as of late, with the current housing crisis in Saskatoon and the lack of shelter capacity, you know, getting women who are pregnant and homeless admitted into MAT services so that they're not freezing to death in our cold winters. Direct lines to detox and mental health and addiction services, connections to opiate assisted recovery services, referrals to parenting support. So actually any mom who comes onto the PORT program automatically receives a kids first worker. We also, through our partnership with Healthy Mom, Healthy Baby, are able to provide nutritional vouchers to all of the moms on PORT. So ensuring that they have regular and consistent access to milk, eggs, and vegetables. We provide transportation, intensive cultural support, and referrals to counseling. And most recently, finalizing a partnership that will allow us access to semi-supported apartment units, 27 of them in Saskatoon, so that we have rapid access to housing, regardless of, you know, whether that mom is on income assistance or has no income, that we can quickly house women who desperately need to be housed without having to deal with the barriers that the current income assistance program presents us with. We also offer and dual plan, actually more times than not, with Child and Family Services, because our mandate really is the prevention of the apprehension. It is not the prevention of the need for a connection to Child and Family Services, especially if you look at our reasons for involvement. Oftentimes it is substance use, and so you know, many of our moms do an amazing job of achieving sobriety, but they still need that ongoing monitoring and support. That connection with housing, to securing income, you know, identification is a big one. Most of our moms don't have any ID, and that's a process because, I mean, if you don't have ID, it's pretty hard to do anything. So, and then we generate a lot of referrals postnatally for support for moms and babies. PORT also, you know, provides postnatal support until we feel that mom is ready for us to transition out our support, and they're ready to just engage with existing community supports. Challenges that we see currently, again, are the high rates of crystal meth and entrenched lifestyles of the population that we work with. You know, a lack of appropriate addiction support and trauma counseling in our community. We are seeing women referred very late in pregnancy. And certainly we still work with them, but you know, our interventions are best when we have a significant amount of, not a significant, when we have more than, you know, 2 months to support those moms. Incredibly high incidence of severe history of trauma, and again, that lack of trauma counselors, and the newly introduced CIS program. I think most people are aware of the multitude of issues that program presents us with.